Good afternoon, dear audience. My PhD topic is improving outcomes in acute life-threatening emergencies. My name is Gergő Szabó. I work as an emergency physician in a county hospital in Székesfehérvár in the emergency department and in two different ambulance services, as you see. With my team, our vision is implementing new approaches and making unproven conventional treatments obsolete by providing scientific evidence that could improve outcomes in emergency care. And the mission is to provide scientific evidence to prove the above and implement evidence-based patient care on a wider scale in my professional environment. My two projects focusing on different physical conditions. The first one is the usefulness of a bedside ultrasound modality called Point of Care Ultrasound in patients who is treated with acute onset dyspnoea. And the second one is to find the best type of infusion in patients who is admitted with diabetic ketoacidosis. So let's focus on my first project, which title is The Effects of Point of Care Ultrasound Use on the Improvement of Clinical Outcomes in Patients with Acute Dyspnoea. It will be a systematic review and a meta-analysis. We know that when someone is admitted with dyspnoea, it can lead a high 30-day mortality, even 13%. And to make a correct differential diagnosis is often so complicated. It can delay treatment. We learned in the university the conventional modalities, the conventional approach to examine a patient, like inspection, auscultation with a phonoendoscope, percussion, and waiting for the results from the labor and from the opinion of the radiologic expert, what is on the chest X-ray or on the CT scans. These attitudes are often time-consuming, and in life-threatening conditions, it may lengthen hospitalization. We know that PoCUS enhances early treatment, but the evidence is uncertain, or I would say it was uncertain. My aim is that our study will assess the efficacy of PoCUS versus the mentioned conventional approach or length of hospitalization in patients who is admitted with acute onset dyspnoea. You see my PICO. So the population is patients who is treated with dyspnoea. In the intervention arm, we examine different types of bedside ultrasounds, the PoCUS. I would say that these examinations were made by not a radiologic expert, but any kind of other doctor. So an intensivist, an internal medicine doctor, an emergency physician. In the comparator arm, we evaluated the effect of the conventional diagnostic methods, and I'll show you in the next slides the outcomes. So I conducted a search from more than 11,000 articles. We found finally 15 which were eligible to get the data extraction. And in this slide, I want to show you my first outcome, which is time to diagnosis, measured in minutes, which is clinically so important because when patients in a breathless condition, it is crucial to get a quick diagnosis. You see that the result is so heterogeneous. I want to highlight the source of this. The first one, the Zanobati article, is from an emergency room where the doctors who made the PoCUS were, I would say, experts, so with a lot of practice. In contrast, other studies where that was the case. In the Corsini, for example, so in the fourth one, there were subjects from a pediatric ICU, so they were absolutely newborns in their first day, so it's absolutely after birth. And for example, in the Székesfehérvár, so in the last article, it was a study where a rapid response team was called to the ward to help make a decision that what is the best treatment for the patients, whether is it necessary to admit to the ICU. So it was again another type of PoCUS examination. So with this limitation, you see that you can achieve with this modality more than 1 hour time reduction, so more than 60 minutes time reduction to get a diagnosis, which is mathematically significant and clinically absolutely relevant in an acute care setting. And when you have got a diagnosis, you can begin your treatment. And again, so heterogeneous result, because these studies are from, again, different countries, and the population was not the same, neither the intervention. This limitation, you see that you can achieve nearly half an hour time reduction to begin your treatment in patients who is treated with acute onset dyspnoea. This result is, again, statistically significant, which is very important. When we could make a diagnosis and we have the chance to begin our treatment, there's a logic question whether our treatment was appropriate or not. According to this slide, with a homogeneous result, with a statistically significant number, I can state that giving your patient a PoCUS expanded physical examination, you can ensure 2.36 times higher odds to get an appropriate treatment, in contrast not to use this bedside modality. I think it's absolutely clear and obvious how useful this modality in our daily practice. Some words about the length of hospital stay. I have got three slides about this. The first one focusing on the total in-hospital length. You see there is a very, very moderate effect on this one. But when we discussing about just the emergency room, you see that you can achieve more than half an hour time reduction, which is our daily practice, very important when you see an absolutely overcrowded emergency room and you can discharge your patient quicker with using this modality. And evaluating the usefulness of the PoCUS in the length of stay in the ICU, you see again a statistically significant and clinically absolutely relevant result that expand your examination with this attitude. You can achieve more than 1 day time reduction in the length of stay in a very expensive and often dangerous area, I mean the ICU. And I want to highlight that the mean number of length of stay in the ICU was not weeks, but just days. If you see the mean on the PoCUS arm, it was 4 days, and in the control it was nearly 5.5. So it's a significant and clinically absolutely relevant result again. The hardest outcome is the mortality. We see that there's a moderate effect on the 30-day mortality, but focusing on the in-hospital mortality, we see that all the studies favoring PoCUS, just the last one, the Lausen, which is a single-center study, and all the PoCUSes were made by one person who is an expert, but it's a bias. So we made a leave-one-out analysis for the last one, and in this way, you see again a significant and statistically and a clinically relevant Austrasian reduction to use this attitude. To sum up my study, the strengths that the huge number of patients who were examined, and it will be the first and most comprehensive meta-analysis indicating that the PoCUS-guided treatment has potential outcome benefits. There are some limitations. I have already made the risk of bias assessment, and I'm working on on the grade assessment. And as I mentioned, we've got some problems with the homogeneity of the patients, the different type of ultrasound, and so on. But we can conclude that PoCUS seems like a preferable modality as first choice to make differential diagnosis in early appropriate treatment, resulting in better outcomes. So what is the implication for practice? All patients who is admitted should be examined with PoCUS with this size handle device in order to shorten time to diagnosis, time to treatment, and all the outcomes. But of course, other studies are necessary, which should be better prepared in order to get even more results. Thank you. Excuse me. I prepared a 10-minute presentation, so just 2 sentences about my second project. It will be the title you see, the effects of saline versus balanced crystal diffusion on the resolution of DKA. And this is my last slide. So here we are now. And thank you for your audience. And I want to finish my little bit longer presentation with my professor's quote, "Diagnosis can wait, but cells can't." Thank you very much. Excuse me.
Congratulations on your progress and presentation. My question is about, of course, your first project. My theory that the heterogeneity can be high due to the different level of skills in the investigators. What do you think about it?
Yes, I absolutely agree with you, and that's why I mentioned in the implication for other results, other research, that more precisely detailed PoCUS protocols should be evaluated in the future. Yes, it means on the one hand the protocolization, and the other the practice for the examiners also.
So can you give us an insight that why did you have discrepancy at this level?
Perhaps because that was my first selection, and also for my first selection, so we are beginning on this topic. But on the other, we discussed with more practice experts like my professor, and he said that it is not easy to find which article is suitable. You see, we included the last 15, but these articles were also so heterogeneous.